Next up is Dr. Shane Burch. It's my honor to present him. He's a professor of orthopedic surgery, director of the Spine Surgery Fellowship at UCSF. He'll speak on sarcopenia and frailty in adult spine surgery.
Well, thanks, Carl and Lee and Lionel for inviting me. This is a topic of considerable interest of mine, and hopefully I can impart some of my interest to you. So I don't really have any disclosures that are relevant. So the overview for this talk is really going to talk about aging and frailty and sarcopenia and how these terms are used, and then really kind of talk about it in a global perspective versus a disease-specific perspective as it relates to the spine. So we're going to start off with the case. So this is a female. She's got progressive back pain and leg pain. We've followed her for about 4 years. So she's got a garden variety degenerative scoliosis. And I mean, most people in this room would be sharpening their osteotomes just looking at this x-ray. But, what if I told you she was 82 years of age? Maybe that would cause some pause. And so the question that this case kind of represents is how old is too old, and how do we determine when somebody's indicated for a deformity surgery? So then if I told you that she's 82, but that she works part-time, she walks 2 miles per day, and she's one of the fittest people that you've seen in clinic, does that change how you're going to manage this patient? And so it brings up the question of the choice of treatment options. Is surgery an option at all at somebody who's 82? And how do we make that decision? And, why do we need to know? Why do we need to have some algorithms to treat these patients? Well, what if this patient walks in? Again, she's 92, and this patient came to see me a few weeks ago, and she says, I'm going to live to 104. I need treatment. She's got a lot of back pain. She lives independently. She does not want to be in a wheelchair. So again, higher stakes. What do you do? How do you make that determination whether she's fit enough for surgery? And so it gets to the point of what's the aging population? And 65 and up is increasing. 85 and up has doubled. And, it's a silver tsunami. We're going to be forced to make decisions on how to treat these patients. And that's what this kind of talk is trying to get at. So the interesting thing is that people who are older have a higher mortality rate, but also people who are older tend to show greater improvement when you operate on them. But they get complications. This is a paper of complications in patients over the age of 80, and they're significant. And a complication in somebody who's 80 is different than a complication in somebody who's 60, even though it's listed as the same type. If you get a heart failure or you get a cardiac event when you're 80, it's probably going to do something a little bit different to you than if you get atrial fibrillation, stress-induced, when you're in your 40s or 50s. So we have to think about the type of complications that these patients get. And, it's what Dr. Lewis is saying. We think about our outcomes in terms of our outcomes, like our Oswestry Disability Index, and a lot of our alignment parameters have been based on ODI and SF36 and things like that. But what we also have to think about is mortality and complications. And so trying to come up with a formulation, we have to think about those things, but also the magnitude of the effect that we're going to give a patient on any given day, that duration, so how long is the operation going to last, and how quickly the patient is going to take to recover. And these are all things that I think we need to build into our decision-making algorithm. So it gets down to the whole concept of functional versus chronologic age and age and risk. And as I said, mortality rates rise with age, but there's tremendous individual variability. So chronological age is simply defined as years since birth, and physiologic age, active rate at which the body is aging. And so what is aging? And it's probably easily defined as a progressive loss of physiologic adaptability, which increases vulnerability to environmental challenge. It's kind of a mouthful. But then there's this concept of there's good things in our life and bad things in our life. The good things in our life are kind of keeping us alive. The bad things like stress, inflammation, environmental factors are causing cell death. And you get enough cell death, you start to age. That's the concept. And then the concept of frailty kind of morphs from just the chronologic versus physiologic aspect of aging, and it kind of tries to individualize the rate of aging. And so again, you can think of any person at a given age, they get a stress response, and one person's now going to become dependent on loved ones, society, whatever, versus somebody who experiences that same type of hit and they're not going to. And that's kind of the concept of aging. So it's some people have a disproportionate change in their health status. And it's not really disabilities, and it's not really comorbidities. It's a different concept. So somebody can have a lot of disabilities or comorbidities, but they might be quite healthy. So for example, you could have a Parkinson's patient who is very well treated, or you could have somebody with coronary artery disease that has had a couple of stents. And even though they have a list of comorbidities, they may not have any kind of disability, and they may not be frail at all. So frailty, there's different concepts of frailty. There's the accumulation of deficits model, and there's kind of the phenotype model. The accumulation of deficit model is kind of what's been probably put around in the spinal literature quite a bit. So again, a list of comorbidities. So if you come up with a list of 40 comorbidities and a patient shows up in your clinic and has 20 of them, then they got a frailty index of 0.5. And the phenotype's a little bit different. It's kind of what we see in the clinic. It's like, how active is the patient? Does the patient have weight loss? Do they have stamina? Or do they have energy? And I think for me, the phenotypic aspect of frailty matches what I see in clinic and can be kind of used a little bit better, at least for me. So this is the Canadian Health Study on Aging, and they kind of defined frailty. And essentially, they had a score of 1 to 7, 1 being patients are completely independent, they're active, and 7, they're completely dependent on loved ones to kind of go through life. And this is the global aspect of frailty. Basically, the people who have a high frail index have a high mortality, they have high complication rates from any type of interventions. People who are not frail do not. So this has been written about in the spinal literature in adult spinal deformity. Here's a list of parameters that were included in the frailty index. And there's correlations, good correlations, statistical significance to things like, wound issues, length of stay, complications. But the point is that this is great from a research perspective, but it's really difficult to synthesize in clinic because you have to have all of these outcome measures. They take different questions from different outcome measures, and you have to list of comorbidities to really get a frailty index. So it's not really a rapid method to analyze how quickly or how frail somebody is. But nevertheless, frail patients don't have the same functional status as not frail patients. However, when you normalize their data to outcomes, the frail patients actually do as well as the not frail patients. They never get as good as they are, but they actually, their delta is the same as not frail patients. So that's kind of interesting. So here's the phenotypic version of frailty. So this is a 5-point scale, and it's broken down into weight loss, exhaustion, slowness, so like how fast somebody can walk, activity level, and weakness. And you get a point for having sort of one of these things. And so if you're more than 3, you're considered frail. And to me, this is kind of like what we see in clinic. We can ask these patients these things. We can give them a grip strength meter and determine their weakness. We can actually get up from a chair and walk across the room. And you can get a sense of whether somebody's frail or not in your exam room. And to me, that's pretty important. I looked at about 1,000 of my patients over a 6-year period, and it's amazing how well this phenotype correlates to outcomes. So all the major indices like SF36 and ODI and NRS scores correlated extremely well with frail status, and also surgical outcomes as well. So again, it's been written about in the literature. If you're frail, you're going to have higher complications, higher length of stay, readmission rates are going to be higher. And I think that's pretty fair to say. Everybody appreciates that. That's it's not a shocker. So that's kind of the global perspective of what frailty is. And sarcopenia is pretty similar to frailty. The sarcopenia, by definition, is the poverty of flesh, although it's the right type of flesh, really, when we're thinking about spine surgery. We don't want a plethora of certain types of flesh. We're talking about lean muscle mass. And it kind of, again, gets this whole age-related decline in lean body mass, nutritional status, independence. And again, globally, it's related to increased adverse outcomes, including falls, mortality, et cetera. And here's an example of a patient of mine that came to clinic the other day. You can see how the extensor mechanism in the lumbar spine is completely filled with fat. The multifidus is spared, but the longissimus is just completely filled with fat. And so this would be kind of a visual of what sarcopenia would look like. And again, AO put out this paper talking about increased risk of PJK and complications from people with sarcopenia. And so again, not a shocker really that when you have these patients globally, it's going to be probably a negative outcome. So really, frailty and sarcopenia are surrogate measures for functional status. And so now what I want to do is kind of get into the disease-specific aspect and how we have to think about how we use sarcopenia and frailty in terms of preoperative management. So everybody's kind of familiar with this cone of equilibrium. And the concepts that I want to bring up here, the difference between alignment, which you've heard a lot about and heard a lot about for the last 10 years, versus balance. And there's a big difference between alignment, which is a great radiographic parameter, and the way I'm going to define balance is more of a physiologic parameter. So you need big muscle groups in order to stand upright. You need glutes, you need obliques, you need multifidus, you need quads to move about your day. If you don't have those muscles, it doesn't matter how well aligned your spine is, you're just not going to do well. And so we need to think about the differences between balance and alignment. And one of the things that we often teach is when somebody's standing in our clinic, we look for mechanisms that they do to kind of overcome their malalignment. So things like flattening out their thoracic spine, bending their knees, retroverting their pelvis. These are things that patients will do to overcome malalignment. But they can only do that if they have muscle that's intact or neuromuscular system intact to allow them to have these mechanisms to help them adapt their malalignment. And this is kind of a biomechanical perspective of that. So if you think of the gravity line and define balance as a gravity line, so if your gravity line kind of falls through your head, middle of your thoracic spine, your hips down to the ground, you actually don't have to use a lot of force to stand upright. But if that gravity line falls forward, then you have to use a lot of your extensor mechanism in order to stand upright. And you're going to put a lot of force on the tissue in your back, in your body, in order to stand upright. And that, as we all know, becomes fatiguing over time and in part leads to pain. But this is the concept, is when balance is off and the gravity line is off, we need greater strength to overcome our malalignment. And this is a paper that kind of did a nice job conceptualize this. So patients with sarcopenia, the graph on the bottom there, patients with sarcopenia didn't have the ability to adapt to their malalignment. So they basically were hanging off of their lower lumbar spine, and the shear forces on their upper thoracic spine was significant. And when we think about what we do to patients when we do like a thoracolumbar fusion, like a T10 to the pelvis, and they don't have much in the way of muscle mass, we're actually making them hang off their instrumentation, and they're going to put a lot of force on the upper thoracic vertebrae, and that's going to lead to PJK. So I'm trying to bring this kind of full circle, where if you don't have muscle, you're going to lead to higher forces on the vertebrae, and that's going to be a bad thing. So I tried to conceptualize this in my mind, the difference between alignment versus balance. So on the top is on the left there is alignment. So again, that's a radiographic parameter. On the top is balance, and that's a physiologic parameter. And so we're going to go through this 2x2 table. So if you're aligned and you're balanced, essentially that's a normal spine. You don't need to do anything. But if you're not aligned, but you're balanced, that means you're able to use the compensatory mechanisms that I was talking about. That means that you probably have the ability to evoke, your neuromuscular system to compensate. And that's the sweet spot. I think that's the spine surgeons, that's the sweet spot. Like when we fix somebody and we align them, we know that the patients are going to have the ability to have that reserve and have the ability to compensate, and they'll be able to stand upright. On the top right box is patients who are aligned. So if you lay them down on the table, get an x-ray. But when you stand them up, they're not balanced. Well, that's not your spine. So you shouldn't be operating on those people. So that's either a hip problem or truly a neuromuscular problem. It's not your spine. And then finally, in the bottom box is where they're not aligned and not balanced. And this, to me, is the tricky part. And this is where we really have to think about, is this patient frail or have sarcopenia? Because these are the patients that we realign and then say, oh, look, they got PGK, or oh, look, they can't stand up straight. And it's because we didn't assess them properly. So the ones on the bottom right there are the ones that I struggle with. And those are the ones I think we need to have more work on. And if you look at the outcomes of our alignment stuff, and we figure out like why we're not knocking it out of the park with all the math that's going around in these papers, it's because we're not looking at the bottom right box here. And that's just static. I mean, when we actually get people to move, that's a bigger thing. And then motion analysis is hopefully in the next 10 years going to be the thing that kind of really breaks us through to the other side. So here's some examples. So a patient on the left is somebody who's aligned and balanced. Patient, second one in, is balanced, not aligned. Third one is a patient that I aligned her, but she's not balanced. In other words, it doesn't matter what I do to her spine, she'll never stand upright. And then the fourth one, she's unbalanced and misaligned. And the question is, if I aligned her, would she ever be balanced? And then here's some images from some early work that we did. So patient just getting out of a chair. Whoops. So patient standing straight up, right? Looks pretty normal. Versus this person trying to get out of a chair. I would say that this person has frailty or sarcopenia. Right? Can you imagine if I did a T10 of the pelvis on this patient? What do you think is going to happen at T9? No matter how much cement I put in there, it's going to break. So that's the point I'm trying to get at. All right, here's another example. 66-year-old female, 8 out of 10 back pain, difficulty standing and walking. Looks like a great case. And then this is her bending forward. And then this is her trying to get out of a chair. Right? Time to put the osteotomes away. Go for coffee. So, and then, there's other parameters, which I'm not going to really go into, but, some patients have, we kind of looked at their range of motion of their hips, and people with short hamstrings can't get their cervical spine below their pelvis. That's what these graphs are. The one on the left, patient can't get below their pelvis. The one on the right here, patient can get below their pelvis, but it's how fast they do it, their mechanism, and which they try to bend forward and bend backwards. There's a lot of velocity parameters in there, which I'm not going to go into. But these are the type of things that we need to really think about when we fuse somebody and we say, hey, you dropped a piece of paper, dropped a sock, you got to bend over and pick them up. You got to reach for something on the table. Like how they move, how they can compensate for their spine is something that I think we need to really look into in the next, it's going to take a decade. So, and I think this is where you have alignment and balance, but frailty and sarcopenia is just a different dimension in this matrix. And I think that we need to start thinking about that. So in summary, I think that, frailty and sarcopenia for sure affect our patients globally. But I think as spine surgeons, we need to do a better job at thinking about how it affects our patients and who we should operate and who we shouldn't operate on. And by no means do I have the answers. This is just an observation over the last few years. So thank you. Any questions? Steve?
Do you think we'll ever get to the stage where you can put a number and objectify all these factors and make a score and then put someone in a kind of low risk, high risk, or are we getting there? Yeah,
I do. I think that there's some simple stuff like, the timed up and go test, getting out of a chair, walking. Honestly, I have this motion analysis system in the clinic, and having looked at probably 150 patients now, I just get patients to bend forward and bend backwards, like try and touch the floor. And I can kind of predict I shouldn't say I can predict. I'm getting a sense of who's going to struggle after surgery and who isn't. And I think with low-grade tech and high-grade AI, we're probably going to get there. We're going to have like a capture system that says like, whoa, you're not moving right now. You're not going to move very well after surgery either. So.
Shane, as we've discussed, I think that we still have some issues in terms of alignment and balance. And I really like the way you've captured this with that 2x2 grid. I think that needs to get in the literature. I think that's really important and it's very insightful. As I think you and I agree, we under-recognize neuromuscular pathology in our aging population. And my question is, I think your talk really correlates well with what Emmanuel talked about earlier, osteoporosis and frailty aspects. How much of this is reversible before surgery? So how much of the frailty phenotype is modifiable?
I think a lot of it's modifiable. The problem that we have is it's more the question of how fast you can do it. And the parameter that drives a lot of our surgeries is pain, especially radiculopathy. And if the radiculopathy is foraminal stenosis, you need a fusion to fix the foraminal stenosis, et cetera. So I think if you said, hey, I'm going to take 2 years, I'm going to reverse this, I'm going to put you on a physical therapy program, put you on Forteo, I'm going to do those things. In a perfect world, you could reverse a lot of it. As you know, if we said that to a patient, they're going to go next door and get somebody else to do it. It's also very expensive. Who pays for it is the real problem. But I 100% believe it's reversible. Yeah. Yeah, Ace?
Yeah, Dr. Burch, thanks. Very comprehensive. 2 questions. Number 1, any easy, quick radiographic parameters, whether it's fat infiltration percentage or psoas signs, or that you use commonly to say, okay, this person sarcopenic. And number 2, what are your thoughts on anabolic supplementation? I know this is out of the box, but say testosterone for old, frail women with very little muscle mass to help prep them like we do for anabolic bone medications.
Yeah, I think that the easy stuff is both radiographic and also just, asking the patients a few simple questions. So that frailty phenotype is, you can ask the patients if they exercise. Of course, they're going to fudge a little bit, but, if somebody's like playing tennis 3 times a week or pickleball, whatever, and they're exercising, they have an exercise routine, they're probably going to be in the good category. And then if you look at their imaging and you see like a robust psoas muscle or, extensor muscles, that's a good sign. If you're seeing like a lot of fatty infiltration, they don't have an extensor mechanism. So, they're going to hang off their implants. So I think it's a combination of just a few questions. And honestly, like asking them to get up out of the chair, how fast they can watch them. If they rock forward and backwards, it means they don't have good quad strength. If they go straight up, they've got good quad strength and, take off out the door, they're probably pretty good. It's quick and dirty. It's not like, obviously there's going to be a cutoff and I don't have a cutoff. But I can definitely dichotomous be like good, bad. I just don't know where the cutoff is. All right, thanks.